Each year, Microsoft Research hosts hundreds of influential speakers from around the world, including leading scientists, renowned experts in technology, book authors, and leading academics, and makes videos of these lectures freely available.
Us from Boston, Harvard School of Public Health. Neil received his PhD from the University of Washington. We've known him over the years as a plan recognition person. It's one of the hardest areas of artificial intelligence to recognize what a robot or human being's plan is from their actions over time and potentially from data sets. He's done some good work in that area, some focused on user interfaces, an important area for Microsoft Research. After he did his PhD work, he was at the Mitsubishi Labs, Merle Labs in Boston, where he worked with such upstanding citizens as Paul Viola and others. Then doing what more of us should do, probably, after some reflection and a successful career as a young man in plan recognition, turned his interest to public health. And he's returned after his PhD at University of Washington to the Harvard School of Public Health recently, and he's been thinking about a really important topic of how technologies, including low-cost technologies, might be used in healthcare to save lives and enhance health. So today he'll be speaking about gadgets for good, how computer researchers can help save lives in poor countries. Neil.
Thanks very much, Eric, and thanks for arranging this talk and having me out here. And thanks, everybody, for coming. As Eric said, I've been going to school since the fall, and I've switched over to thinking about international health. But as you can see, I didn't get too far from my roots, proving the old saying that it's easier to get the boy out of computer science than the computer science out of the boy. And one thing that I learned from my computer science days was always to start a talk with an example of the kind of problem you want to address. And back in computer science times, I would try to choose a cute or a fun example, to engage the audience. But of course, the examples from public health aren't a lot of fun. We study things that make people sick, things that kill people, and there are a few better examples of that than the HIV/AIDS epidemic. There's a picture of Samuel Morin dying of AIDS. There are worse pictures to show, but you get the idea that AIDS is often called the slimming disease or the wasting disease, because people really wither away from it as they suffer from it. Now, one thing that distinguishes public health from the related field of medicine is that we tend to focus less on individuals and more on populations. So we're more apt to spend our time looking at statistics of the kind you've probably heard. There's an astounding 40 million people, we think, with HIV, 95% of them in low-income countries. Most of them don't know their status. It varies a lot by individual and by region, but a fair guess is you've got about 9 years to live if you get HIV without treatment. And most of the 3 million people who died last year probably didn't get much treatment. And so when you hear that the numbers went up by 2 million, then realize that probably 5 million people got newly infected last year because 3 million people died. Now, there's some good news, which is that the drugs for AIDS are quite effective. Antiretroviral drugs, as Samuel Morin a year later. Sometimes it's called the Lazarus effect because it really brings people back from a weak state to a strong and vital amount of health. You have to take the drugs every day, so it's a difficult treatment, but it's really effective. The mostly bad news is that of the 6 million people that we think need treatment, last I checked, it was listed that 700,000 or so were on treatment. The little bit of good news here is that it's a lot more than it was a while ago due to concerted efforts by the affected countries and the international health community. And so there are some similarly bad stories you can tell about tuberculosis or malaria or child mortality. But this talk is also about how computers can help. And Samuel Morin got his treatment from a group called Partners in Health, which is a shining example in the international health community of a group that gives very high-quality care to very poor people, largely in Haiti and Peru. And they use, even though they don't have enough money for CAT scans or all the medicines they want, they set up computers in clinics in rural Haiti and with satellite phones and power generators. And they use those computer systems to help monitor and manage the care from Boston, to generate lookup lists of people who need follow-ups for visits, to do drug inventory. They're looking to expand their care and generalize their systems. And so this is computers can help. There are computers out there in these areas, so it's something that we could work on. And furthermore, you all have had kind of an indirect effect in this story, in that a lot of the money that big grant that Partners in Health got came from the Gates and Melinda, Bill and Melinda Gates Foundation. Sort of general funding, not specifically for the computers. And that this foundation is has recently appeared on the field, and it's one of the largest funders of global health. And so that's a bit of an introduction of the talk. For the rest of the talk, and it's a nice small audience, so feel free to interject your thoughts. I think we have a good amount of time. But what I'm going to do is tell you a little bit more about where I came from and why I'm here today, talk a little bit about how everybody else in the world is doing, then talk about some of the techniques that I've learned from international public health, some preliminary ideas on how computers can help provide tools for healthcare workers, and then end up with a little bit more about me and where I'm going. So my background, as Eric nicely covered, I got my PhD just down the road at the University of Washington in AI, then did research at the research lab in Merle. And we have an old joke in artificial intelligence, which says that you work on the areas in which you're not personally very good at. So if you're not very organized, you might work in planning, as I have. Or if you're not very efficient, you might work in optimization, as I have. Or if you get lost a lot, you might work on a navigation problem, as I have. And let's just say I'm sort of more of a breadth person. I've worked in a lot of different areas. Inference intention is what I'm calling plan recognition that Eric mentioned. And even though I've done the most work in that, I put it there because it wasn't quite as funny in the early ones. And perhaps having worked in a lot of areas made it easy for me to shift over to public health. And I imagine some of you are here because you're kind of wondering what it'd be like to shift from computer science to an area that focuses on social impact. And it's been great. It's consisted of taking a lot of classes. We had a 5-week field trip to India. Really learning kind of a new perspective. Computer science has one way of looking at the world and deconstructing problems, and public health has another one. It's been useful to get kind of indoctrinated in that way of looking at the world. And I'm just now starting to work on some research projects, all of which have a significant IT component. And for today, I want to sort of give you a flavor of the field that I've been learning about. I want to sort of generate excitement for the idea of working in international health, and hope that you'll want to talk to me again or hear from me again in a few years after I've gone off and can speak from a little more experience about what works and what doesn't work. Before I get to the bulk of the course, just a few caveats. First of all, I've given you some numbers, and I'm going to give you some more, and you should be skeptical of them all. Because countries have incentives to exaggerate numbers to get more funding. Countries have incentives to underestimate numbers to protect tourism. There's not the data quality. There's lots of error and noise in the data that's gathered. There's a lot of pressure to generate numbers, and once the number's out there, it kind of sticks. And so I've done the best I can, but you should realize there's probably a lot of error in some of these numbers. Also, in a short talk like this, I'm going to neglect a lot of hugely important issues, including all the disadvantaged groups in wealthy countries like the United States. I'm going to gloss over a lot of complex issues, like governmental corruption is a very complex issue in international health. The paternalistic nature of this effort and this the title of this talk, a bunch of people over here trying to save a bunch of people over there. It's a little worrisome. I don't know if it's true, but I'm told in the 1800s, as the Europeans were on their way to conquer Africa, all the rhetoric describing that endeavor was talking about how they were going to bring enlightenment to an unenlightened people. And so you have to be careful and be cautious of this as you go. And finally, there might be some people here listening who have a lot more experience than I do. They might have lived in or worked in low-income settings. And feel free to chime in if you have thoughts. This talk is really geared towards people who knew as little as I did a year ago, which is to say not very much about international health, or the world, really. And so getting on to everybody else. How are people doing? And public health really, as I know it, focuses very much on the basic needs of people. So not animals or plants, not high literature or art, really much more focused, a little bit the environment, but mostly then again how it supports people's lives. And one place to start with how the people on the planet are doing is how many of us are there, which is a concern for international health. And as many of you know, there's 6 billion or 6.1 billion and counting. And here's a little sketch of the world's population. And this will show you how population growth isn't as big a concern as it was 20 or 30 years ago. It took about a million years to make our first billion people. But just like with money, it takes people to make people. And so we knocked off our second billion in just 123 years, our third billion in 33 years, our fourth billion in 14 years. And so you can probably understand, like in the 70s and 80s, there was a lot of concern about explosive population growth. And there were Malthusian predictions of hundreds of millions of people starving in the coming decades, which fortunately hasn't happened. In fact, fertility rates, the number of children, the number of average children that a woman has have been going down almost everywhere in the world. There's a few places where it's going up. There are some areas where population growth is still a concern, but largely it's subsiding. In wealthy countries like the US, population growth is a concern, but only in terms of total mass of people, not the total number. And obesity is one of the huge public health concerns that I won't be addressing here. But then, as you can see, you can even see here the rate has gone down, and it's expected to go down quite a lot more. And so it's still an issue. We're expecting 3 billion more people on the planet in the next 50 years, but there's not the concern of the explosive population growth that there was worries about before. But maybe more importantly, how are the people on the planet doing? And from the perspective of this talk, it really depends on where you live. The billion or so people living in rich countries have had just a terrific 100 years. Our prosperity has unprecedented growth in our prosperity, great growth in our longevity, declines of things like child mortality. It's really done well. And the lower and middle income countries have had losses or much smaller gains. And certainly it varies by region. There's some areas that have done quite well. But say the few billion poorest people who live on $1 or $2 a day are living in really extreme circumstances where there's not enough many people don't have access to clean water, people don't have access to clean sanitation, extremely crowded living situations, very little opportunity for yourselves or for your children, tremendous inequities between the genders. And there's a lot you can say about what's wrong with this picture. What I'm going to focus on is poverty being a risk factor. If somebody is poor or in poverty, what can you say about their lifespan and their health? And to illustrate the concept, I'll show you for what passes for a fun example in public health, which is the sinking of the Titanic. And what this data shows is that the more you paid for your ticket on the Titanic, not only did you get better accommodations and food, you also had a better chance of surviving the trip. And this is what's called a nice dose-response relationship, which is what epidemiologists really like, which is that the more you paid, the higher your chance of survival was. And this is real data. It's a little bit misleading, I think, because this is one of the very few circumstances in which it's protective to be a woman. And I think there were a few more women in first class than third class. So there are a few things going on here. But taking that idea and going to a more serious and current example, and I think these are some of the most disturbing numbers in the talk, we could take a look at Malawi, which is a small country in the southeast of Africa, and look at its health stats compared to the US. And as you can see, the life expectancy from birth for Malawian is a mere 38 years compared to more than twice of that in the United States. And a lot of that happens at the lower ages. You have a very high probability of dying very young in Malawi. A Malawian infant has an 11% chance of dying before the age of 1 and an 18% chance of dying by the age of 5. And that's terrible of itself. If you think about large family sizes of 6 or 7, a lot of families have to endure the loss of an infant or a toddler. And even at the higher ages, only 50% of the people live past the age of 40. Many of us probably know someone in their 20s or 30s who have died, and it's a real tragedy when that happens. But it's also very common in Malawi. And I put for correspondent in the U.S., 13% of the people die before the age of 60, which is much later in life, and a lot of that is probably in the disadvantaged groups. And certainly part of this comes from a high burden of HIV in Malawi, but a lot of it has to do, and it's correlated with just being a low-income country. Malawi is sometimes called the 5th poorest country, and if you chart GDP or average GDP per capita against life expectancy, you see a strong correlation. And Malawi is one of the worst off, but lots of the low-income countries have similarly low life expectancies. So we'll revisit these numbers in a little bit, but I want to now talk about some of the techniques from international public health and how you think about and address these problems. And starting with how do you measure population health? And if anything crystallizes for me the difference between the last years and what I expect to be in the coming years, it's how I'm going to measure the success of my projects. And there's a lot of work in public health to measure population health, both to see whether your projects are working well, or see whether intervention works well, and also decide how to allocate resources. You have to know if you've got so much money, you're going to put it into tuberculosis, malaria, or HIV. And so an obvious candidate, which part of the title of the talk is about saving lives, is to just count mortality, count number of deaths. And in some cases, that's appropriate. You want to do something and you want to see mortality rates go down. But it's actually not a very good measure of population health. And to demonstrate that, we could look to our neighbors to the north and south. The death rate among Canadians is 7.6 per thousand per year, and Mexico is only 5 per thousand per year. And that's a little counterintuitive. Should we be diverting all of our aid to Canada because they have higher mortality rates? But it's not that Canadians are less healthy, as you'd expect. It's that Canadians are older. And older, healthier people will have higher mortality rates than younger, less healthy people. And so a better metric, which is commonly used, is life years lost. And it's a simple idea. You pick some target age of life, say 80 for men and 82 for women, and then when someone dies, you calculate the delta between their current age and that target. And sometimes there's a little bit of question about whether you should use regional life expectancies to compute these kind of things. But usually people agree the whole idea is that everyone in the world deserves the same target length of life. And so, for example, a 40-year-old woman who dies corresponds to 42 years of life years lost, which is worse than, say, 5 75-year-old women who die in terms of life years lost. So if you're comparing diseases, you'd be more interested in the one that affects the younger woman.
Well, I guess it's also the issue of, from a Western point of view, the investment a culture makes, a civilization is made in a person.
Yep.
I'm curious if you looked at the, I know there's for negligent homicides, for example, in auto accidents, there's insurance rates based on someone's abilities and their age. I'm curious, traditionally, how the investment and their experience trades off with the life years lost. Maybe interesting to see what they do. Do you think about that?
Yeah, so in a few slides, you'll see a more complicated metric, which has some of these economic measures in it. And in fact, what I was going to tell a story of is that there are cultural assumptions bound up in this kind of metric as well. There was a famine in northern Uganda, and it was a severe and kind of sudden one, and there were some relief agencies. They had a little bit of food, and they wanted to give it to the children, which is a natural impulse and consistent with this metric. And the community wanted to and did give the food to the elder people, and caused a lot of consternation. And as the Western agencies understood it, the reasoning was, well, young children are easier to replace, and older people have the wisdom which is necessary to continue the community.
Triaging, automatic trauma care triage system analysis once, and understrapped resources in a county, do you transport the little kids or the older people or the middle people and so on? And it actually, these metrics will control who gets transported to the trauma care centers.
Yeah, and if you have only so many people that you can treat with, give AIDS treatment to, do you treat your health workers first? It's a very practical thing because you need them to take care of everybody else, and there's a lot of concerns about who to prioritize.
A lot of it, sorry.
No, please.
A lot of that too, the cultural perspectives has to do with quality of life too, because if you're living in dire poverty, and the length of your life really. I don't know, I lived in Latin America for many years in very rural, poor villages, and, in their mind it's a very short-term view, and they want to get as much as they can in their short existence, but they'd rather have a higher quality of life than a longer duration. And if they're expecting or wanting to live to 82 but worrying about every meal, then, doesn't really.
Yeah, that shows up a little bit also in the second metric I'll mention, but it's there's a lot of complexities, and so even so, life years lost or slightly more complicated metrics are used very commonly to allocate resources and measure product. And to reinforce the concept and to make a bit of a political point, I'm going to compare the number of life years lost by the recent tsunami tragedy to low life expectancies in Malawi and Sub-Saharan Africa. And so when I made these slides, what I saw was that from the tsunami, 180,000 people were listed as dead and 120,000 listed as missing, so that almost all of whom are certainly dead. And I just guessed, since it was more younger people than old people were killed by the tsunami, that the average life years lost was 65 per death. So that gives me comes out to about 19 million life years lost from the tsunami. And if you compare that to low life expectancies in Malawi, there are different ways of computing it, and I wanted to do it on a per year basis. And so I multiplied the total population of 12 million by the mortality rate, which is 24 per thousand, much higher than Canada and Mexico put together, and 42 life years lost per death based on the life expectancy. And that comes out to be about 60% of the tsunami. But Malawi is a really small country, about the population of Ohio. So imagine that you heard that 60% of the tsunami victims turned out to be from Ohio, and it was happening every year. And again, this is a bit of a manipulation. But to continue it, if you go to Sub-Saharan Africa, you get a much larger population, a slightly lower mortality rate, a slightly higher life expectancy, and if you crunch the numbers, you get 20 years of life years lost, 20 tsunamis worth of life years lost per year. And so the political point is, it's great that the world gave so much attention to the tsunami incident. I was in India on that field trip when it hit, and so I think that amount of attention is warranted, but it's a little shame that there isn't more kind of similar outcry for some of these quieter things that happen. And then here's that more sophisticated metric, which is commonly used. And I'm going to go through it a bit fast, but you'll get the idea. And there are a few different ones that are used. This is one of the common ones. If you see like global burden of disease in the paper, it's often based on things, these disability-adjusted life years, or DALYs. And on the right here, you can see the top 10 causes of lost DALYs based on 2002 estimates. And the three ways it's more sophisticated are, the first is sort of a quality of life metric. So it says if you have a disease which makes you depressed, or let's say make you paralyzed from the neck down, but doesn't kill you, they ask these kind of silly questions to health experts to assign weights to what it's like to live in that health state versus a healthy life year. And then which is a bit arbitrary and has some controversial elements to it, but it's good in that it lets you say things like depression is the fourth leading cause of DALYs in the world, fourth leading cause of harm of a certain kind of way, even though it tends not to be associated with high mortality rates. And then the last two complications are these more economic metrics, and so they weight the more productive years higher. So the years like between 20 and 40 are worth more than the younger years and the older years, and I think that reflects that those are the age at which you're contributing economically to society, and you're taking care of the younger and older people. And then they also, this was devised by economists, they also discount future years. So if a 5-year-old dies, their 25th year is still very valuable, but it's not as valuable as a 24-year-old person who dies, because they discount that 25th year that's productive, but it's 20 years in the future. And so it turns out there's a smaller difference than you might expect for the lost DALYs for a young child dying than for an adult. And again, I think it reflects kind of this practical reality that it's important to, or it reflects the economic contribution that people make in their 20s and 30s and thereabouts. So that's a lot about what's wrong. Certainly, we're wondering what kind of things can we do about it. And just to give kind of a broad picture of it, there's a new, somewhat recent campaign called the Millennium Development Goals, in which a lot of important people, a lot of big-name economists, and including the rock star Bono, are going around saying things like this, that we're the first generation that can end extreme poverty. And they're talking on the order of 30 to 50 years it can be done. And certainly, with all great visions, there's a fair amount of hype in this. But the more I learn, the more I think there's also a fair bit of truth. And it's certainly a stirring concept. And of course, health isn't the whole picture. There are lots of ways into improving people's well-being. And the good news is they're all kind of positively reinforce each other. So if somebody has more money, then they could afford more education. If somebody has more education, they could get a higher job. If somebody has more money, they could afford more health care. And there's a strong correlation between being higher educated and better health. And just to elaborate the links coming out of health, if it's a hugely important issue that health problems force people into poverty. It's a little hard to fathom, but they say that 3% of India's population gets pushed into poverty every year by health problems. And the typical scenario is that a family member is sick or dying, and then as things get really severe, the family borrows a lot of money to try to save that person, and then goes into poverty. And then coming out of health, education is a little more obvious. If you're sick, your children are less likely to be able to go to school, or if you're in school and you're sick, you're less likely to be able to learn well. And so people argue a little bit about what's the right way to put all your, what's the right allocation of resources for these different ways in, but probably the truth lies somewhere in the middle, and they all certainly need to be done. And I'm going to focus on health just because that's the area that I know a bit about. And then just pretty briefly to give you a sense of the kind of interventions that happen, reducing child mortality from 18% to a small percentage isn't about high-tech hospitals or advanced prenatal units. It's about pretty simple things. It's about bed nets to prevent malaria, or vaccines to prevent measles, or nutrition to give kids the ability to survive all the kind of diseases. The top left is a picture of a young child getting oral rehydration therapy, which is sometimes called the greatest medical innovation of the century. It's essentially kind of like Gatorade for people with diarrhea. So if your child has diarrhea, you want to replace their salt, water, and sugar to replace the nutrients and fluids that they lose. And it was developed in the 70s or so. They made a really simple formula that was easily reproduced. It's a real story of a public health success. They went around and they taught it to a huge number of rural women in Bangladesh and India. They sent people around afterwards to make sure that the teaching was effective. One of the problems that came up was you need to be able to measure a liter of water to mix the solution, and people don't have a liter measuring cup. So they went around with a liter measuring cup, poured it into containers, and made a little mark so that people would know what a liter was. And so this was, like I said, done in the 70s, and it's still estimated to save between 1 and 2 million lives per year. On the lower left is a picture which has not quite so much success yet. If you noticed, the leading cause of lost alleys was lower respiratory infections. And a big cause of that is indoor smoke pollution. So you have somebody cooking in their dwelling, and the fire produces a lot of smoke, and it's almost always the woman and is cooking, and so she's breathing in the smoke, and the kids are often right there, and so their lungs are especially vulnerable. And it causes at least a lot of mortality and illness. And it's a hard problem to solve. Sometimes the fire is there for warmth as well, a lot of cultural things bound up in it. But it's expected that if you could just keep the kids 6 feet or so away from the fire, that would reduce their exposure substantially. And again, I think that's easier said than done, but it's, I think, an ongoing or upcoming public health effort to try to work on that. And then maybe even more briefly, I've talked about HIV treatment or AIDS treatment. There's also lots of very effective measures to reduce the transmission of HIV using on all the modes of transmission. So for sexual transmission, that's the upper left is one of the more colorful condom ads that we saw in India. And on the upper right is community outreach to commercial sex workers to help them negotiate condom use with their customers. You could do needle exchange programs to prevent transmission among injecting drug users. And then the third mode of transmission is from a mother who's HIV positive to her child. There are pretty good, cheap drugs to reduce the probability of that. Again, in the lower left, breastfeeding is one of the most complicated parts of this because you can transmit HIV through breastfeeding, but there aren't really viable alternatives to breastfeeding in a lot of cases if you don't have clean water or you can't afford formula, and breast milk conveys a lot of important immunological protection. But still, there are better, worse ways of doing it. We think that 6 months exclusive breastfeeding is the best technique to use to maximize immunological protection and minimize prevention of HIV. And so spreading that technique is a public health intervention. Okay, so that was a bit of a romp through public health. Now I'm going to talk about some of the the ways that computers can come in. You'll see it's some preliminary stuff. There's no, I think, one example that's completely, the perfect thing. I'm hoping to put out a lot of ideas. I've got a fair number of slides, but I'm also happy for this to be a brainstorming session. So feel free to jump in, or feel free to sit back and see what comes. And what I'm going to focus on is information and communication, broadly defined. And so in case anybody's been too busy to notice, we've had another information revolution in the last 5 or 15 years. It's been a revolution of cell phones and satellite coverage and GPS and RFID and web search and the web in general, and faster computers and peer-to-peer networks and a lot of other things. We now all kind of depend on a daily basis to get through our day on things that no one could do 10 years ago. Everyone probably has their favorite examples. And all these advances also give us the opportunity to address what I'll call fatal information deficits in healthcare in low-income settings. And some of you might be thinking that somebody living in extreme poverty doesn't need information. They need clean water. They need medications. And I think you can actually make some good arguments for why providing information access to everybody could have some good long-term benefits or even some short-term benefits. A good example is there are, I think they recently found a way to provide storm warnings to fishermen in Southeast Asia, and that saved a lot of lives. But I'm going to talk about information deficits that sort of more directly relate to health. And so, for example, if you look at drugs, there are quite a lot of important information deficits. So even though there's not enough money for drugs, that money also isn't spent very efficiently. For one reason is that there's just not good knowledge about what's in stock or what the expiration dates are of medicines. And so a lot of medicine in rural clinics expires and gets thrown away. Or there's too much of one medicine and not enough of another. And again, it's just because there's not much knowledge about what's needed or what's there. A similar problem is logistics. So if we want to do the kind of scale-up of treatment of AIDS that we'd like, it involves a nightmare of a logistical problem of trying to get all the drugs to all the places they need to go efficiently under the constraint that you could never have stockouts because if people stop taking the drugs and they start developing resistance. There's an information deficit in terms of diagnosis and treatment. So even when there are drugs available, you need to get the proper diagnosis in order to take advantage of them. And there's a substantial shortage of doctors and nurses, especially in rural areas. I heard that there are more Malawi-trained doctors in the UK than there are in Malawi now, which makes sense because there's people could go to the UK and get much higher salaries and take care of their families. And also, if you go to a clinic, it's unlikely that there's much medical history is available to the person who is treating you, which is important, especially for kids, where you want to be able to track their development. On sort of the population or regional or government level, governments have some amounts of money and they need to decide how to allocate it. And to do so, they don't have currently very good information about what the problems are. It's a dynamic thing. It changes seasonally. It changes as infectious diseases spread through regions. And the ability to track that better is important to be able to just make better use of resources that you have. And similarly, it's kind of a big optimization problem. Lots of things are being tried, and you want to be able to quickly be able to replicate the successes and stop the failures. And currently, there's lots of gaps in the quality of information for assessing that. I heard recently they revised the estimate of the number of cases of the particularly bad kind of malaria from 250 million to 500 million. So that's a big factor, and just gives you a sense of how hard the problem is that 250 million cases were being missed before. And then even on the individual level, there are studies showing that people don't take maximal advantage of the health care that's available to them. For example, they might not go seek care based on the symptoms that they or their children are having at the right times. And then there are lots of ways of using technology to address all these problems. In a kind of an abstract level, you could try to connect the medical expertise that exists to the people who need it, either directly through telecommunication or by encoding that knowledge and delivering it through, say, a decision support system. Electronic medical records can help with drug inventory, as well as providing patient medical history. Intelligent tutoring can be used to train healthcare workers more, or to perhaps spread health information to everybody. Sensors can be used to gather more information about what's going on, and then if you have a lot of information, there are data mining and visualization problems for how to manage it. And there's also a lot of work done on how to sort of cover ways of improving connectivity in general in poor and mostly rural areas, which is important for kind of anything else to work. So I'm not going to go through these all. But just to give an example, and there are good examples of computers working in these areas, mostly kind of on the pilot level. A nice one is done by a for-profit company in Boston called Dimagi in collaboration with the Ames Medical Institute in India. And they provide handhelds for nurses going door to door and do medical record systems on those handhelds. And the main value is now they have some information about the patient, like their immunization record and so forth, when they're delivering care and checking the development of the children. It's small but not tiny. They have 80,000 records or so in the last few years, and they report a very impressive cost of only 25 cents per patient per year for the whole system. And they've now...
But you could immunize all of Thailand for that quarter, right?
For that. Well, it's a measles vaccine. It's like 12 cents. But yeah, it's a real question. I mean, these computers have to pay for themselves to be worthwhile. And they're now moving to cheap desktops that maybe cost a couple $100s and can run off car batteries for clinics. I think it's partly because it's an easier platform to develop on. And then a project that I've joined that's a little more preliminary is called DTree, a little more AI-ish. It's similar to the last project. We want to put computers in the hands of frontline healthcare workers, but to provide a high level of decision support or guidance as they're delivering care. So regional governments or the World Health Organization devise standard treatment protocols or algorithms or procedures for going step by step for how to deliver care. And so one way to look at DTree is a way of deploying and monitoring and updating those protocols. And it's hard for reasons you can imagine. You know, if a protocol comes out, you have to tell everybody it, which is hard to do in person, but easier with computers. The algorithms, they're called algorithms, they're not perfectly executable. The inputs to these algorithms require a fair amount of assessment. You might have to know whether the person in front of you has oral hairy glaucoma or thrush, and we can provide pictures or explanations for that. Some of the other inputs are things like tracking how much weight the person's lost, and you can do that more easily on a computer, or even whether or not somebody has chronic unexplained diarrhea can be broken down into more questions that we can provide. And so we can provide support for executing these algorithms. We're currently focusing on HIV protocols, which say when to start people on drugs and when to change their drugs and how to treat any opportunistic infections that arise. Our first target is we'd like to eventually be able to improve the quality of care in places where there are no physicians. But our first target is a little more modest, which is to go to places where they're trying to scale up the treatment of the rollout of AIDS drugs, but the bottleneck is the number of trained physicians or highly trained nurses who can deliver the care. And so our idea is to use this system with less trained healthcare workers to filter out the easy cases. So if somebody comes in and they're kind of doing the same as last time, if they're on drugs, there's no major side effects, or they're not on drugs yet, but they've had no major symptoms to warrant going on drugs, then we could take care of those, filter those out, and only the more complicated cases refer to physicians. And then a huge benefit of all this is that you not only hopefully improve the quality of care at the point of service, but you're also able to download information about what's going on because you're capturing that kind of as part of the workflow. And so every few weeks you sync up. So this is designed to run on batteries, maybe in areas where there's no standard connectivity or standard electricity, but every once in a while you're going to go sync up, get the data, and bring it back to home base, and that's going to give you a lot of ability to monitor how these algorithms are working and what are the needs out there. This project is led by Mark Mitchell, a pediatrician who's a professor at Harvard, and he's not a technologist. He's a pediatrician who's been going back and forth to dozens of these countries for 20 or 30 years, and so he was brought to this by seeing the need that he thought he could fill.
Is PALM the device that is being used for this?
The first proposal was looking at PALMs, although.
Why PALM versus Pocket PC or a Microsoft?
That was made before so I'm not. I think probably it was just on what seemed easy to get. That's just before I got there. And actually, for our first target, we're thinking about also going to desktops. Computers run off of these car batteries because we'll be in a clinic situation where there probably is more electricity. But so I don't have a good answer to that question. If you have thoughts, I'd be happy to.
I was just wondering what the decision was as to why PALM versus a Pocket PC or something.
It's a good question, and I don't have much to say about the trade-offs, and probably it's at a preliminary enough stage that probably not a lot of commitment was made to that choice.
I assume they're going with standard handcrafted protocols. There's an opportunity, of course, with long-term medical informatics stream to compile out from decision models, dynamic policy, including dynamic inquiries of patients. But this is probably a good first step.
Yeah, actually, and Mark's interested in that stuff, right? So if you had a model of the disease, and let's just say you had a BaseNet model of it, you can guide treatment.
We should talk with Microsoft in 1990. Our team worked with us in 1995 or so, 1996. Built pediatric BaseNets with UW, and we fielded them on MSN for a while before we took them off for a variety of reasons for business policy at Microsoft, but they could be used for this kind of thing.
Yeah, absolutely. Again, there's some politics and responsibility issues, and so delivering the protocols provided by somebody else is easier in some ways, but absolutely. And so to jump off something where I'm going to have a few, a little more sort of a broad problem without too much of a solution specified, talking a little bit about the information deficits in individuals. And there's like I've been careful to say that poverty is often the root cause of ill health, but even so, people can often take actions which will improve their health or protect, in this case, the example I'll give here, protect their children. And there are lots of things you can do. So I mentioned before, trying to keep children away from the smoke of fires. Parents often will withhold food from their children when they have diarrhea, which reduces the incidence of diarrhea but increases its mortality. And so that's a behavior worth changing. And then there's a practice of rubbing dirt into an umbilical cord, which also adds complications. And there are cultural problems and issues wrapped up in all of these things, but they also all seem addressable through health information. And then so how can computers help with that? And I'd say there are a bunch of tools we have at our disposal, things like interactive tutoring or testing to see what people know, or you can imagine using animation and games as kind of a powerful media to get a message across. Just to run some numbers, let's suppose that you create some contraption or whatever of laptops and virtual reality or projectors or PDAs or what have you that one person can take around and use to convey health information. If you get your equipment cost down to $1,000 per year, and if it doesn't require a highly educated person or a much educated person to operate, then $4,000 a year operational cost for the person is reasonable. And let's say you could present to 10 people per day or 3,000 a year, and I'm just making this up. Let's say 200 presentations saves a child's life, which seems reasonable in areas where you have such high child mortality. Then if you run those numbers, you get $333 per life saved, which works out to about $10 per DALY, which is competitive. There's a figure going around. The World Bank says $150 per DALY saved is cost effective. Economically, yeah, exactly. That's not a bad price. So like vaccines are probably the most cost effective intervention, and they're probably like in the $10 range.
150 is, but I mean, is that considered to be a good current rate, or does that actually bring back returns worth more than that? Mm-hmm. What are they saying? No.
Just
that's the current going standard.
Current going standard. You've got so much money to spend on, and you want to get the most DALYs you can for your dollar. That's a reasonable rate.
Because you probably could compute economically how much you should pay per DALY to optimize the return economically, including quality of life years.
Right. So there's cost-effectiveness analysis and then there's cost-benefit analysis. And cost-benefit analysis tries to put everything into dollars.
Right.
And it gets...
Including happiness.
Yeah.
And lifespan.
And what tends to happen with that analysis, as far as I've seen, is they tend to ignore happiness and lifespan. And they look at only the economic values, like how much you're going to return economically. And somehow, if you're forced to put a money value on a year, you have to justify anything that you do, you have to put such a small value on that year that it's really mean.
Right, but my guess would be that there's actually quite an interesting functional correlation between the economic vibrance and someone's assessed total life reward and happiness too. They're not disconnected.
Yep. I'll get to your question in a second, but just to make this point, which is that Eric was just saying, there's a lot of second synergies that you get from this kind of thing. So if you lower child mortality, there's a strong correlation that after child mortality goes down, shortly afterwards, fertility rates go down. And the rough thinking is people don't have to have as many kids to make sure they'll have some kids to take care of them when they're older. And reduced fertility is also very strongly correlated with better health and better wealth, because you can invest more in the children you have. There's less of a drain or need for resources on the family. And so there's a lot of secondary benefits which are in line with Eric's point with that.
So on your example for the behavior change system, I'm somewhat disturbed here, because if you can train this one person to use a quite putatively complex system, surely you can use that same amount of time to train that person to convey the behavior change,
Right, that's a good point.
The education of behavior change, and then that person can certainly present to more than 10 people a day. And a human-to-human interaction is more likely to be much more successful. And so I'm a little bit disturbed by this particular part of the analysis. And I think that this might be not a great place. Behavior change is probably not a good place to introduce computer technology.
Well, I'm going to throw out one more idea. We can see what you think of that I think scales a lot better than people would. And I think it's a fair point. You could people-to-people training is a good candidate. I guess I could imagine that these mediums can be very effective partly because media just has a strong impact, and that it might be easier to scale a system because it's difficult to train people who can go out and train people one-on-one. But it's a fair point. I don't have a strong opinion about where the trade-offs lie. Let me throw out another idea, which certainly scales pleasantly, which is to develop short interactive courses which you can deliver over a cell phone, and so. Maybe last 5 or 10 minutes and are interactive in the sense that ask you to press 1 if you would do this, press 2 if you should do that. And then the key concept is that at the end of the course, you get a little test to see if you've absorbed the material. And if you pass the test, then you get credits for personal calls. And so that's a powerful incentive to have for people to go for the courses. And you can have the voice or the things recorded by local celebrities, perhaps, to make the whole thing more attractive. It's also pleasant in that in the teaching session, you can ask people like what they would do in a situation. Would you reduce food or increase food? And so it's an effective teaching technique, and also would help you gather information about what the current beliefs are in an area. There are a lot of cell phone coverage is very widespread. Cell phones are getting more widespread in a lot of low-income areas. And there are a lot of communities where there's one person, usually a woman, who owns a cell phone and then rents it out call per call. And so one problem with this idea is that you don't want to invade her business, but she might also be able to administer the whole process. And so I would say that if it works, if it's effective, something that's really pleasant about this idea is that it scales very quickly. Compared to anything else I can imagine. Do you care to?
That one seems more plausible. In the other case, I really would strongly recommend, if anyone is going to pursue the previous version as a research problem, they need to do this study that says, if I train one person, what is their reach? What is their effectiveness? If I have this device, what is its effectiveness? I mean, there has to be a human-human study on that one. And this one that one seems a little bit more reasonable.
Well, the other factor to consider is which kind of program is easier to manage. And so maybe that the computer program, it may or may not be that the computer system is not as effective as human-to-human if you have a good teacher, but that it's more difficult to do a wide-scale program where you're sending out lots of people to do teaching. Those are all the concerns that you have to factor out to see where it makes the most sense. So I've got a few more ideas to throw at you, but just take a little break is to the question about whether or not do we really need research. So let's say I've convinced you that computers can help, but is it the kind of thing that computer science should attend to? And I'm interested in either case. But just to have a few thoughts on this, I saw a nice Buddhist quote recently which says that because the problem is so urgent, we need to proceed carefully. And even in the best of cases, extreme poverty is going to be with us for a long time, 10, 20 years. 30 years, 40 years. And so we have time to apply the techniques of science. And then just to borrow an analogy, there's, I think, a very important concept in the field, which is the 1090 gap, which is that only 10% of the total amount of effort and money spent on medical research, which is responsible for a lot of the gains in wealthy countries in health outcomes, is devoted to the problems which afflict 90% of the world's population. And the Bill and Melinda Gates Foundation may have actually moved that number a little bit, but generally it's still very low. And so people are using 20 or 30-year-old TB drugs, and there aren't yet any malaria vaccines. And there's no reason to believe that those problems couldn't have been cracked if we had brought to bear the power of medical research. And there's lots and lots of people who need it, but most likely it hasn't been addressed because those people don't have much money to buy the drugs for. Although again, some of that's changing a little recently. But so if we think about computer science, what's the gap? Charitably, it's 199, and so I think that it's be a great thing to shift a little more work and spend a little bit more of computer science effort to try to figure out how to take all the advances in technology and transfer them as quickly as possible to the needs in low-income settings, or develop new technologies that are appropriate there. And just to throw out a few more ideas to go for different regions, and I'll wrap up soon if we can have a little bit of discussion. This is a picture of a chalkboard that we saw in a clinic in India. And so at the clinic, they record what they're doing on a chalkboard to monitor their progress and so forth. And this is the kind of information that we really would like to have on the regional or government level. And I use the word surveillance here. When I was back in computer science, surveillance was kind of a negative word, or a kind of a disturbing word. But in public health, surveillance is kind of a much more positive thing, and it refers to ongoing and systematic collection of data so that you can compare progress between different regions or one region over time. And so the idea here is just to, can you throw a camera on this blackboard and automatically extract the information on it. And the point here is that it's coming up with ideas of doing passive surveillance, I think, is really important. You'd like to just tell these people, do everything you do, and then at night type into a computer and tell me what's going on in your clinic, or fill out forms. And that just won't happen because it doesn't add any value to them. It's extra work, which adds more to their burden. And so if you have a method where you could extract some data without adding much burden, that has a lot of power.
You'd be surprised how useful that would be at UW Medical Center and Stanford and so on, too. I mean, this is a very familiar scene in hospitals, at least today.
In wealthy countries, yeah.
They use whiteboards, though.
Right, so maybe we could make a dual-purpose technology. Another technology kind of along those lines is there's a digital pen out, which you have to work on expensive paper, but you just write your forms and then the pen captures what you've written. To say a few words about telehealth. So there's enough doctors in the world, but they're not in the right places. And so it's very tempting to use technology to connect the doctors that are there to patients who in say rural areas. So for example, connecting the Malawian doctors in the UK to Malawian patients to overcome language barriers. And just to say a few things about it, there's this classic version is sort of doctor to patient remotely, and that's hasn't had great success in the past, but maybe is up and coming as technology improves. The most common variation is doctor to doctor or doctor to healthcare worker, which has had more success and hopefully will have more success. There's ideas of just connecting healthcare workers to large data repositories. There's a company called HealthNet that's made a lot of health information available to and accessible in areas that are fairly remote. And then like an interesting variation I heard recently was you've got a doctor who tends to some rural community, and so it's difficult to get from place to place, and maybe makes the rounds every couple months, and so builds relationships. But in between those visits can use telecommunications to stay connected to the patient's needs. And there are lots of technical challenges for this. The fact that you're not with the person, you could have sensors to replace the fact that you can't touch people. You could better use of bandwidth, maybe focus in on the face and use higher resolution there. And then lots of user interface and design problems. And just to wrap up, let me say that one thing I found is that it's easy to generate ideas, which not only are exciting to me, but generate excitement among people working in the field. That there's, I think we're trained to identify different kinds of information deficits, different kinds of opportunities than other disciplines are. And that's very complementary to the skills that are generally in place in public health. And of course, if you just think about ideas and work on them by yourself, you're going to come up with a lot of stuff which doesn't make sense. And so you really have to work with people in the field, and by that I mean the field of international health, which I have a great respect for, and people working on the ground. And so the answer to how computer researchers can help save lives in resource-poor settings is really just this, to work with people, and I think you'll see a lot of opportunities for things to do. And just I haven't quite figured out the lay of the land for how to proceed in all this. Funding's a bit of a challenge. There's not generally a lot of structure for using computers in these areas. You have to be careful that you're not draining resources that could be used for medications, and make sure that it does pay for itself. But there are a number of new foundations. There are health resources. There's the idea of doing dual-purpose research, both for things like one person's bioterrorism detection system is another's country's outbreak tracking system. And so there's possibilities for tapping into money from wealthy countries to do good in both places. And then my plan for the next couple of years, just sort of my next steps, are to visit a lot of places in the field and sort of field testing some of these ideas to get a better sense for what the opportunities and obstacles are, and for what works and doesn't work. And then just to wrap up with a thing I find inspiring, Vikram Kumar, who's the CEO of that company I mentioned earlier, got the Humanitarian Award from the Tech Review recently, and he came up with a very nice quote and idea, which is that there's a different kind of millionaire that we can aspire to being now, not someone who makes $1 million, but someone who helps a million people. And so thanks very much. And please keep in touch. Send me an email if you're kind of interested in these issues. I like to keep in touch with people who are. Thanks a lot for your attention.
Any other comments or questions from the audience? But one comment, I'm curious if you can reflect a little bit. I know you're a passionate CS researcher. Not that this is not CS research to some extent, but can you reflect a little bit about the change in direction? Had you been interested in this area all along and this kind of welled up, or is it kind of one day you said, something? Collaboration is really hard.
Let's work on something easier.
It's not affecting millions of people.
Thanks for asking. People who know me say it's not surprising, but it was also kind of an abrupt shift. It's felt right when it happened in a way that I didn't feel like I was burning all my bridges, and so it seemed like something worth exploring. But the more I've gotten into it, the more it's felt like a place that I like to work on. And I haven't yet missed doing computer science research personally. And it had been building up in kind of small ways over the last 5 or so years. In different ways, I've been trying to spend sort of more of my time working on socially worthy or socially impactful problems. But public health came up kind of suddenly. I was specifically talking to people who wanted to use the information technology to help scale up the treatment of AIDS in Sub-Saharan Africa. And I talked to them, and the technology part was kind of compelling to me, but it was really just learning more about the AIDS in Africa problem and other public health problems that really got me interested in public health. And about a year later, I was signing on to get this degree program, which it's a very short program. It's only 9 months long, so I graduate in a month or so.
What will you do?
Thanks. There's a good question. So I'm going to, I don't have a particular position worked out, but something that will give me the flexibility to explore things and learn more. That's my main goal, is to get a little more exposure and a little more experience and credibility from contact with real implementation.
Neil, do you think about directly working with a group, maybe like on the ground, as opposed to doing a degree program?
I gave it a little thought. The way it evolved, I kind of applied without too much thought, and then once I got in, I was there. But in hindsight, I'm really happy I did it this way. I think there's probably other ways in, but I feel like that it's really, at this point, having only been on this side of it, I feel like it's really useful to get a full set of the kind of questions you should ask and the kind of things which come up. Like whenever you look at a little problem, it kind of reminds you of 5 or 6 other things. So I'm very happy with having gone this route, and it feels really valuable. And I think if I was in one place, I wouldn't have learned the broad overview, which I feel is really useful. But I certainly would respect anybody who did it the other way, and a little else on your what kind of your economic situation is, and this way it's a little bit more expensive.
The World Health Organization seems to be somewhat based on prioritizing money, and their protocols, don't treat people with certain kinds of tuberculosis. And Partners in Health, which you mentioned, it sort of has the opposite philosophy of, people deserve better, and we're going to do the best we can for each individual. Have you, having gone to school now and some, where do you see a middle ground? Do you see?
Yeah, it's a thing we all wrestle with. So Partners in Health is really an inspiring example of kind of the power of one, of giving, saying people in every situation deserve as good care as we get here. But then when you say I've got $10 million and there are 50 million people or whatever, who need some kind of treatment, it's hard to not want it to be cost effective. So I don't have an answer. I think in each case I sometimes like cost effectiveness and I sometimes don't. I think it makes sense to keep things in mind and to at least always have in mind the ideal of Paul Farmer from Partners in Health, that the right thing is the best quality of care for everybody. It's a bit of a dodge, but you're putting your point on a really important issue.
Another question back to personal reflections. So I went to medical school, I had a PhD as well, computer science, and went into the computing area for interest in cognition and mind. But there was this trade between touching patients and having an impact personally with patients and with populations versus doing something more basic science that might have influence in less abstract ways, more tenuous ways over time. If you could apply your computer science skills right now to joining up with the bioinformatics efforts, for example, better vaccines and new technology diagnoses that are state-of-the-art leading edge that might, in the end, have the same kind of sub-Saharan impact that you could have in the best of cases by being on the ground and educating against proliferation, for example, of disease. But there's a different lifestyle and focus where you're closer to the actual people, and the way you're focusing your career path at this point. I'm curious if you can comment on that.
Yeah, so it's a great question. Just to repeat it for or to summarize it briefly, what about the choice between doing kind of more basic research that might have long-term medical impact that is equal to or greater than kind of this more immediate kind of work that I've been talking about, and I agree that like either one could have the same impact, but I certainly know that I prefer this, to go this route. I think just it's where it feels right to me, and maybe it feels either like I can make more impact, or I'll just be happier with the impact, seeing the impact that I can make. And another variation of it is working on the policy level, which I don't feel. Maybe that's a slightly different case where I don't feel that's my strength. But certainly on the policy level, you could make a small move which has very big outcome. I think I kind of the one maybe reflection I have on it is that I think it's important to be working on and addressing these needs. It's important for the world to be paying more attention to the immediate needs of people, because there's a lot of things that are addressable. And so this is, I don't mean to sound so immodest, but there's a quote from Gandhi that says you have to be the change you want to see in the world. And I think that the change I want more to see is just sort of everybody paying more attention to addressable problems and sort of jumping in where you can. So.
On that wonderful note.